Hi everyone, welcome again to this new week, new topic of our Anatomy Comprehensive MCQ series. I'm Doctor Ankit Khandelwal, Professor of Anatomy, and this week we have devoted ourselves to the topic, and the topic is what? The topic is the neuroanatomy, right? So, from 12th of Feb to 16th of Feb, 12th, 13, 14, 15, 15, 16. So, for 6 days, if you look over here, then we are going to start with we are going to complete the important topics of the neuroanatomy. Okay, so it's going to be a daily session around 8 p.m. As already told you, most comprehensive anatomy MCQ series targeting mainly these two exams, but yes, it applies to other exams as well, including our own FMGE exam. Okay, fair enough. So let's start the first MCQ of the day. Here it is. Question says a 15-year-old boy is brought to the emergency after an accident on his father's farm. So there was an accident. Okay, the examination reveals weakness of the left lower limb. So there is weakness in the left lower limb. Weakness means motor loss. There is a loss of pinprick sensation on the right side. So weakness on left side and loss of pinprick on the right side beginning at T8 dermatome. T8 is somewhere between you can say between the xiphoid process and the umbilicus, because umbilicus is around T10 and xiphoid is around T6 or T7, right? So there is a loss of pinprick on the right side and weakness on the left side. Based on the examination, which of the following represents the most likely approximate location of this lesion? So basically we can understand the lesion lies mainly around the spinal cord. Okay, and when there is weakness, they are referring to the motor tract. And that motor tract is which one? It's basically we all should be knowing it's a corticospinal tract. And when this loss of pain and all, this is basically your spinothalamic tract, that is related to the spinothalamic tract. Okay, vibration and proprioception, that is in by the dorsal column, that fasciculus, cuneatus and gracilis. So this we know, this is the whole thing happening. Now there is a motor loss on which side? On the left lower limb, and this loss of pain is on the right side beginning at T8. So it is T8 and below T8. This is what the question is telling us. Now these are the long tracts of the spinal cord, and we also remember it by a hypothetical syndrome known as the Brown-Sequard syndrome. Brown-Sequard syndrome. Okay, Brown-Sequard syndrome. Now we should know where do these tracts actually cross, both of these two tracts. Now the spinothalamic tract over here, it crosses where? Crosses at the spinal cord level. Okay, it crosses at the spinal cord. Suppose you have to take the pain from the palm. Anything, this pin is striked over here, and that pain is taken up by the sensory nerve in the palm. Say this area is our median nerve, right? It will go to the brachial plexus, into the spinal cord, then it will go from left to right side, then it will ascend up. That is the whole point. While the motor tract, where does it cross? It crosses at the medulla oblongata part. So in the spinal cord, it remains on the same side. Now as the lesion is in the spinal cord and it is the motor loss on the left side, we know that the lesion is basically on the left side. Why? Because motor loss on the left side, motor loss is on the left side, and loss of pain is on the right side. Second thing, they are giving a hint that it started at T8 and below T8. Right? So whenever there is a spinothalamic tract crossing, it will ascend for a couple of segments, then it will cross. First it will ascend for a couple of segments. Suppose I'm talking of where, say this is C6 or C7, right? So this C, say C6 over here, it will go to the spinal cord at around C6. Then at around C5, it will reach C5 on the left side. Then at C5 or C4, it goes from left to right side. Okay. So when they are saying it's starting from T8, it means the lesion should be slightly above T8, and that on the left side, slightly above T8. Left side above T8. This much information we know. Okay, so if you go to the options, option number 1, T6 on the left side, perfect answer. Perfect answer over here. Simple as that. So if you know the basics, answers become very simple. Now option number 2, TC, right side we can rom it. So B and D cannot be the answer. Option C says T10 on the left side, can't be T10, it can't be below. Okay, lesion is below and the sensory loss is above, it can't be that. The sensory loss or the motor loss will always be below the lesion. Therefore, option number A is the answer. And don't forget what told you over here, the Brown-Sequard syndrome. Here's an image. to show you the brown circuit syndrome over here. Do closely understand it. Suppose there is a injury over here in the spinal cord level. On the same side, that is on the right side, ipsilateral side, as we call it as, there are two things which happen over here. What are those two things? One thing is there is a loss of tactile discrimination, vibration and proprioception sensation. So that is the dorsal column tract is involved. Second thing, they are saying spastic paralysis, that is corticospinal tract involvement. Same side, ipsilateral. Well, if you look on the other side, and you can see there's a, one or two segments below. So this is on the contralateral side or the opposite side. There's loss of pain temperature, that is spinothalamic tract. This is what we used to call it as brown sequard syndrome. Okay, so it's an important topic. Remember it. Fair enough. Let's move to the second one over here. The next one, which of the following cranial nerves exits the brain stem? So cranial nerve exiting the brain stem via pre-olivary sulcus. Now this, if you know the answer, it's very simple. But if you don't know it, suddenly becomes a very tricky question. What is pre-olivary sulcus? Right. So see, don't think too much. Olivary sulcus or olive. If you remember the medulla oblongata, there's an anterior midline in the medulla, and there are two swellings around it. These two swellings around it, I am telling you the external features of the medulla oblongata. So these two swellings will be known as what? They are known as pyramid. Pyramid. Why? They have the pyramidal tracts inside them. Corticospinal. Later to these pyramids, what we have the olives over here, having the olivary nucleus. This, what you are seeing, is the anterior view or the ventral view of the medulla oblongata. This is M over here, medulla oblongata. So there are two sulcus. If I put a couple of this red arrows over here, one sulcus you are seeing over here, one you are seeing over here. This one is the midline sulcus. While this sulcus over here, this is in front of olive. So what should it be called as? That is the pre-olivary sulcus. That is the pre-olivary sulcus. So this is OLIVE, this is OLIVE, this is PYR dot pyramid. If there is a pre-olivary sulcus, there has to be what? Post-olivary sulcus, right? And the post-olivary sulcus is actually this one over here. This whole is the post-olivary sulcus. Post-olivary sulcus, olivary sulcus. Now, which cranial nerves come out from where? Between the pyramid and olive, the nerve that is coming out over here with its different rootlets over here, this nerve over here, or let us show with a different color, else hard to decipher. The nerve that is coming out from here, just a second, yes, over here, this is the 12th or the hypoglossal nerve. So it is the hypoglossal nerve and only the hypoglossal, no other nerve, that comes from the pre-olivary sulcus. Hypoglossal nerve, 12th nerve, motor supply to tongue. Answer is therefore hypoglossal over here. But if tomorrow they are going to ask you, okay, tell me of the post-olivary sulcus, all the remaining nerves which come from the medulla, apart from 12th, they will come from post-olivary sulcus. What are those? 9th, 10th and 11th. They are coming from the post-olivary. So remember, post-olivary, what we have? 9, 10th, 11th, right? And pre-olivary, what we have? Hypoglossal nerve, the answer over here. Let me show you an image over here. So this is what we are actually discussing right now. This is P for pyramid, this is O for olive, small o. If I zoom it a bit, you will see this nerve over here. Let me put direct black arrow over here. This is the 12th nerve. Simple as that. And if I put 3 blue arrows, one over here, one over here, one over here, you know what we are referring to. 9, 10th, 11th, post-olivary sulcus. Sir, can we see other nerves as well? Absolutely yes. This you can see the olfactory nerve coming now, number 1. This you can see the optic chiasm over here, and therefore over here you have the second or the optic nerve. This region is the midbrain over here, and I am writing MB, and therefore this nerve coming anterior is the third or the oculomotor nerve. This nerve winding around from behind is the trochlear nerve. Very, very thick nerve over here with the red color, and this area is the pons. This is which nerve? This is a combination of 3 nerves, trigeminal. Tri means 3. Then from the junction of pons and the medulla oblongata, we have the nerves 6th, 7th and 8th from medial to lateral. Why? Because M for M meaning by more medial the structures, more motor the nerve or the tract are in our brain. Understand this. Okay. So you have seen 1 to 12. That's sufficient. Answer for this question was 12th nerve. Let us see the next one over here. A 92-year-old lady, okay, is brought to the emergency by her caregiver. The woman had suddenly become drowsy and confused. 92-year-old, so suddenly. The examination revealed there were no cranial nerve deficits, okay, and age normal motor function. See, it's an important line, no cranial nerve deficits, you'll understand it. But a loss of pain, thermal, vibratory, discriminative touch sensation on the one side of the body excluding the head. Very important finding. Loss of pain, thermal, vibration, discriminatory touch on one side of the body minus head. Only on the body minus head. CT shows a small infarcted area. Which of the following structures is the most likely location of this lesion? Anterolateral system, medial geniculate nucleus, VPM or VPL nucleus. So the options have taught us a few things, but understand on the contrary. When they say that there are no cranial nerve deficits, it tells us that brain stem is normally should be fine over here. Because a lesion around the brain stem, some cranial nerve deficits, they do come, either partial. Then they're saying the loss of pain, temperature and all that sensory sensations are lost from the body. From where? From the body minus head or minus head and neck area. That's very important. Why? Because sensation from the entire body is taken up by what? It is taken up by those tracts that we just remembered, spinothalamic tract or the dorsal column tract. While from the head and neck, what is the sensory nerve of the head and neck? The trigeminal nerve. Right? So here you have the trigeminal lemniscus or the trigeminal nerve over here, which take the sensations from the head and neck. They are saying the CT shows a very small infarcted area, not a very big area, but a small infarcted area. Lesion is not in the brain stem. Sensory issue is there. There is a small infarcted area. What is the sensory relay station of the entire body? That is the thalamus. So all the sensory from the body comes to the thalamus, it relays in thalamus. Okay, let me show you an image over here. All the thalamic nuclei, very important image. Look at a couple of nucleus over here, VPM, VPL. What is VPM, VPL? Ventroposterior medial, ventroposterior lateral. If you look at the VPM, let me change the color actually over here so that it is better clarified. VPL by this color, greenish color. Now if you look at the VPM, it is receiving trigeminal lemniscus, that is from the head and neck. In that question, the head neck was okay. So VPM looks fine. But if you look at the VPL was receiving medial lemniscus, spine lemniscus, that is your spinothalamic tract. Going where VPL? So it was a VPL nucleus which was at fault. Do we have an option over here? We do have VPL nucleus, option number D. That will be the answer. So it's a problem or the infarction in the VPL nucleus, not VPM. If there was combined loss from these loss of sensation from the head and neck also, then we would have gone with the VPL plus VPM. VPL only we are dealing with the body, and if you're dealing with the VPM, it is from the head and neck area, or face area, that relay, sensory relay centers, right? So that's it. Let's see the next one over here. A patient is observed to suffer from hypoglossal hemiplegia. What is hypoglossal hemiplegia? Looks very intimidating term. Hypoglossal is the 12th nerve. Hemiplegia means half body paralyzed. Hypoglossal is 12th nerve, tongue problem. So patient is suffering from this. There is atrophy of the tongue on the right side and deviation of the protruded tongue to the right side. So there is this tongue, right? There is a normal tongue over here. In this case, there is this atrophied tongue over, atrophied on the right side. And if you ask the patient to protrude the tongue is actually going like this to the right side on protrusion. This is a normal tongue, right, left. That is a normal tongue at rest. That is not normal, but this is the, just a second, yeah, this is the lesioned tongue over here. This is the lesioned tongue, but at rest. This is on protrusion. Okay, so this is the finding over here. In addition, the patient exhibits upper motor neuron paralysis of the left side of body. Now, whenever the question says that there is an upper motor neuron paralysis on one side of the entire body, Which tract are we referring to? Which we are referring to the corticospinal tract. One side of the body that is dealing mainly with brain stem. Why? Because we also include the hypoglossal nerve. Where is hypoglossal nerve? We have just seen that lies in the brain stem. Which part of brain stem? It lies in the medulla oblongata. That we know, 9th to 12th cranial nerves, medulla oblongata. So there is a right-sided problem in the tongue and there is a left side problem in the body. Tongue is going to the right side, body is paralyzed on the left side. It's sort of crossed hemiplegia. Deviation of the tongue towards the right involves which of the following? The question was very simple. They just asked, when you ask the patient to protrude the tongue like this, the tongue is going to which side? Right side, with atrophy on the right side. Always remember the mnemonic, which I guess we have discussed sometimes back also, but don't worry. The tongue licks the wound. Tongue licks the wound. What do you mean by this? क्या मतलब है इसका? अगर यहाँ चोट लगी, if you have a wound over here, the tongue will start to do like this. Tongue is always licking the wound. Tongue deviates to the lesioned side. अगर टंग राइट में आ रही है, इसका मतलब है कि राइट साइड की हाइपोग्लॉसल नर्व डैमेज है. दैट इज व्हाई टंग गोइंग टू राइट साइड. Tongue is going to right side, it means right hypoglossal nerve is damaged. And they ask very simply, tell me the reason of deviation of tongue to right side. आप सीधे बोलिए right hypoglossal nerve is the reason. Option number C over here. But if you think about this question a bit in detail, what is this whole question? Hemiplegia भी हो रखा है इसको. This question basically, tongue is going to the right side ना, so diagnosis जो बनेगी, the diagnosis over here would be, there is right-sided medial medullary syndrome, right-sided medial medullary syndrome, याद रखो. Why right-sided? Because right side 12th nerve, but sir body तो left side गई है, because we discussed that the corticospinal tract तो बेटा cross करेगा. It will cross where? It will cross at the medulla oblongata, lower part of medulla oblongata. Damage happened to the right side of corticospinal tract, but as it crosses at the lower part of medulla, body में changes आएंगे on the left side. Clear? Here the tongue image is shown. This is a normal tongue image, and here you can see the nerve supply of the tongue. In this question, we are dealing with the motor nerve, and this is the hypoglossal nerve. And here what you see, this is again an image-based question can come from here. The question which I have seen is asking about the genioglossus, याद रखो. But this hyoglossus is also as important as genioglossus for question purpose. So do remember genio and hyoglossus. Genioglossus basically forms the majority part of the tongue. Let me tell you, I did a very small video on the anatomy of tongue as well, around a month or a couple of months back. If you have time, do watch it. It's an important video. Anatomy of the tongue. It's my entire anatomy, okay, of the tongue area. So genioglossus, okay, and hyoglossus. चलो आगे बढ़ना. A 62-year-old lady is presents with a tremor and ataxia on the right side of the body. Okay. So there is tremor and ataxia on the right side of the body, excluding the head, and with the loss of most eye movement on the left. So tremor and ataxia, tremor means trembling, ataxia on the right side, and eye movement का loss हुआ है where? On the left side. The woman's eye is rotated slightly down and out at rest. So eyes अगर rest पे हैं तो down and out. The left eye is down and out like this. Left eye यहाँ देख रही है ना? This is down and out. And right side there is tremors. ऐसे हो रहा है, and right side there is tremors. The left pupil is dilated. Very important finding. Dilated means कि जो pupil has involuntary muscles like the sphincter and the dilator pupilli. Sphincter pupilli parasympathetic control. Dilator pupilli sympathetic. तो कह रहा है कि pupil is dilated means that the sphincter pupil is not working. यहीं पे आपको पता होना चाहिए कि there is some loss in the parasympathetic का कुछ loss है, which is carried by the third nerve. ये पता होना चाहिए, right? And then when the eyes are down and out at rest, it is also finding of the third nerve palsy. हमें पता है यहाँ तक कि third nerve palsy हो चुकी है. There is a third nerve palsy. Tremors and ataxia अगर यही finding है, is basically problem in the cerebellum. Problem lies mainly in the cerebellum. Cerebellum का काम है ना posture balance and all that, coordination. So cerebellar lesion है, कहाँ पर है? राइट साइड ऑफ बॉडी है. सेरेबेलम कंट्रोल सेम साइड. सेरेबेलर लॉस है राइट साइड में अकॉर्डिंग टू द फर्स्ट लाइन. आई का लॉस है लेफ्ट साइड में. तो गड़बड़ है, देखते हैं. देयर आर नो सेंसरी लॉसेस ऑन हर फेस और बॉडी. बेस्ड ऑन द डेफिसिट सीन इन दिस लेडी, व्हिच ऑफ द फॉलोइंग रिप्रेजेंट्स द मोस्ट लाइकली लोकेशन ऑफ द कॉजेटिव लीजन. अब यहाँ पे there's confusion. Cerebellum तो कह रहा है cerebellum is saying that I am having issue on the right side, third nerve कह रही है issue on the left side. अब कहाँ जाए? You look at the options, there is cerebellum on the left, cerebellum on the right, midbrain. अब third nerve comes from the midbrain, तो यहाँ midbrain भी सही है. Okay, now try to understand. Suppose we have this black line as the midline. इधर right side है, इधर left side है. Is that clear? तो clear? Now cerebellum कहाँ का जा रहा है? राइट साइड. सो assume this blue box as to be the cerebellum. ये cerebellum है. And consider this red box on the left side to be the midbrain. ऊपर होती है ना थोड़ी सी, ये midbrain है. ठीक है, फाइन. इनमें लीजन है, हो सकता है. Now if there is a lesion, ध्यान से सुनो, listen carefully, only on the cerebellum, we can explain the first line, ये ट्राइमरी ataxia हो राइट साइड में, but we can't explain third nerve palsy. Because third nerve never ever comes to cerebellum, directly or indirectly. तो cerebellum का तो lesion we can't explain actually, explain कर नहीं पाओगे. Then sir, how can we explain midbrain? We can explain midbrain, the reason being that cerebellum से जो fibers जाते हैं, which they ascend up, via याद रखिए, there is a cerebellar peduncles over here. So it is basically the superior cerebellar peduncle from where the fibers will go and they actually cross and reach the midbrain. याद रखो, on the opposite side. So, क्या बोलेंगे सर इसको? We call it as dentatorubro fibers. Rubro means for the red nucleus. Dentatorubro, वैसे तो complete name is dentatorubro thalamic fibers और tract बोल दो. Dentato is a dentate nucleus of cerebellum. This is dentato, cerebellum का part है. This is rubro, red nucleus, ये thalamus हो गया. So midbrain we can explain. Now midbrain किस साइड गई है? Of the left side. So आंसर हमारा सीधा हो गया, midbrain on the left side. So you can explain the third nerve loss. You can explain the cerebellar loss on the right side. That's the whole point. So question was all about, do you know the simple circuits of cerebellum? But sir, you said the cerebellum controls same side of the body. Question आएगा आपके माइंड में. But how it is crossing then? Actually बचपन में याद रखो अपना स्कूल टाइम का, माइनस इंटू माइनस क्या होता है? What is minus into minus? It is plus. -5 multiplied by -5 कितना हुआ? It is +25. वही चीज यहाँ पर. The cerebellar fibers actually they cross twice, दो बार क्रॉस कर जाते हैं, फिर ऊपर गए, then they, and when they come down they again cross. So as they cross twice, minus into minus, result is same side. याद रखना इस बात को. Okay? Question was good. Understand circuits. This is just a coronal section because we have kept in, हमने पूरा सेशन रखा है whole week for images. So but understand this image here. This over here is a coronal section of the brain. यहाँ पर this area, this is our cerebellum. Remember, understand this. This over here, if I put with say white color, ये क्या है? This is the LV, lateral ventricle. This is number 3, third ventricle. ये दोनों side LV. Okay. Now if I highlight one area over here, यहाँ मैं कुछ highlight करता हूँ. This area, ये कौन सा part है? Which part of the brain it is? Think. 3 number is third ventricle. Third ventricle is a cavity where it is a cavity in the diencephalon. तो यहाँ लिखता हूँ D for diencephalon. इसमें thalamus आता है. Below diencephalon we have this shaded part. We कौन सा part है? This is actually the area for midbrain. Why sir midbrain? Because you can see the thicker area below it. उसके नीचे आपको thicker area दिख रहा है ये वाला. This is the pons over here. This over here is the pons. उसके नीचे भी कुछ दिख रहा है. हाँ सर, उसके नीचे भी कुछ दिख रहा है. क्या दिख रहा है? This thing over here, ये क्या? This is the medulla oblongata. This is our brainstem. This is the medulla oblongata. Right? यहाँ पे और चीजें देख लो. This over here is the lentiform nucleus, जिसमें अंदर की तरफ you have the globus pallidus, बाहर P for putamen. This over here is the C. C से क्या होगा? Caudate nucleus. This is C for caudate nucleus. What are these? These are parts of basal ganglia. या basal nuclei बोल दो. Now if I put a more one highlighter over here, ये क्या है? This thing which I'm highlighting again and again दिख रहा है इतना बड़ा. What is this? These are the projection fibers and they are known as the internal capsule. क्या बोलते हैं ना? We call them as internal capsule. Okay? It's a coronal section. ऐसे काटा गया, separating the brain into anterior and posterior part. याद रखो. These are few things, important things over here.